Good morning. This video presentation is to discuss legal and professional issues in prescribing. We're going to discuss the federal drug law, controlled substances misuse, state law, ethical aspect of prescribing, and what does the MP is able to do outside of the United States as prescriptive authority. A little review about the history of the federal drug law. Basically, the Food, Drug, and Cosmetic Act in 1906 was created to basically protect the public by restricting the manufacture and distribution of drugs. This was because many children were dying due to non-investigated drug. The manufacture was adulterated and many children were poisoned by drugs that were not under investigation. After this, in 1938, the law was had an amendment, and it's because the pharmacological effects were not tested, and therefore toxicity of the drugs were unnoticed. Uh, a lot of children, more than 100 children, were dying as well due to this. In 1962, again, another amendment passed that restricted drug adulteration, misbranding, and the interstate commerce of unapproved drugs. And at this level, it was mandated to do preclinical animal trials before testing drugs in any kind of human being, especially in children. Then the FDA Modernization Act passed in 1997, and this basically come up with classification of drugs as prescription and non-prescription. Um, Basically, the FDA mandated uh, which type of drug would be dispensed with or without prescription. The FDA basically made a request for pediatric data on drugs because many drugs were not tested in pediatric population. That's when they come up with the pediatric rule. Since the pediatric rule came up in Research Equity Act in 2003, um, several drugs that were already on the market were removed because they have never been tested in pediatric population. FDA Modernization Act as well provided a 6-month extension of the patent when the drug was coming from brand to generic. And this is because, again, as I said, it provides that the advertisement of the prescription drug must conform to the labeling, and the majority of the drugs were not tested in pediatric population. So it was very important to test the effectiveness of all these drugs in pediatric population as well. So as I previously stated, in 2003 was reinstated the pediatric exclusivity, and basically was mandated to test all the drugs already outside in the market in pediatric population, otherwise they would be removed. In 2007, um, the research basically approached any therapeutic gap in pediatric population and also examined the adequacy of the pharmacological action and side effects of the drug in this particular population. So basically, it's important to know what the FDA regulates. FDA basically, again, classifies drugs as prescription or non-prescription. Uh, FDA has a caution that federal law prohibits dispensing drugs without a prescription if they're legend drugs. Um, they approve the process of new drug or new indication. They also require surveillance of adverse drug events and clinical trials, stage 4, post-marketing. Um, they also regulate medical devices as well. Provides that the advertisement again of prescription drugs must conform to the labeling. Any advertisement that describes a drug use must contain the generic name and the amount of active ingredient. Now let's talk about the process of new drug approval. Um, Preclinical research is done in animals. The outcome is to optimization um, to be suitable for testing in humans. Early drug development consists on preclinical activities designed to support clinical trials and clinical drug development. So the initial phase of preclinical research um, entails manufacture, formulation, packaging um, of a sufficient amount of high quality drug material for both definitive animal safety testing and clinical trial use. So basically, they test animal toxicology and pharmacokinetic in the animal, not the human. This is basically in preparation for the rest of the phases. Preclinical research again establishes the potential efficacy and safety of a compound for use in human trials later, but is basically done in animal studies in laboratory. The mechanism for seeking approval to initiate clinical trials in the United States is the submission of an investigational new drug application to the FDA. So now let's go through the phases of clinical trial. Phase 1, again, even though it was discussed already in class, generally involve between 20 to 100 healthy normal subjects and is basically intended to establish the safety and tolerability of a drug. If high levels of toxicity are expected, such as, for example, in many cancer drugs, patients with the target condition may be used in place of healthy volunteer. But the majority of this phase 1 clinical trial is done in healthy volunteer. Again, it's basically to establish safety, toxicity, kinetics, adverse effects, and also the dosage of the drug. Now let's go to phase 2, may involve up to several hundred subjects with the medical condition of interest. So if I'm going to study a drug against hypertension, basically to treat hypertension, now in phase 2, I would take a group of deceased subjects or volunteers, not healthy. So this group of patients need to have the actual hypertension condition. It does have multiple objectives. Phase 2 includes the acquisition of preliminary data regarding the effectiveness of the drug for treatment of a particular condition. Like phase 1 trial, phase 2 continues to monitor safety because it does enroll more patients that are capable of detecting less common adverse effects. So here we could separate the most common and the rare side effects because now I'm testing it in the actual population and with more um, um, amount of subjects. Phase 3 involve also several hundred to several thousand patients that are conducted at multiple sites in a setting similar to those in which the drug would ultimately be used. So basically, I can test it into a bigger population of hypertension. I can go to different countries, different states, in a nursing home, in different modalities and settings. is basically based on specific clinical endpoint, also known as primary endpoint or surrogate endpoint. Examples of primary endpoints include survival, improvement in patient's functional status, or improvement on how patient feels. Examples of surrogate endpoints or secondary includes markers for decreased disease burden, such as reduction in the plasma level of biochemical markers, for example, to be able to decrease LDL in anti-hyperlipidemics. Um, so those are the phases. Post-marketing research is necessary or mandated sometimes by the FDA uh, to continue monitoring side effects uh, and also to study the disease once already in the market in different populations such as elderly, pregnant women, and children as well. So again, FDA in addition regulates what goes on labeling. Labeling on over-the-counter medications, insert in prescription drugs, um, decisions, for example, if to be able to understand if the medication must be prescribed or not, rationale for scientific principles, and also um, control clinical trial. Each country regulates bodies establish a standard format and organization for labeling an approved drug in that country. A drug label must include the drug proprietary and chemical name, formula, ingredients, clinical pharmacology, indications and use, contraindication, warnings, precautions, adverse drug reaction, etc. So that is what's known as package insert, and that is mandated by the FDA. Another aspect that must be approved by the FDA is drug name. A drug is known by two principal names, generic or brand name. A drug generic name is based on its chemical name and is unprotected by the trademark. However, the generic name must be approved and registered with the U.S. Patent and Trademark Office. So again, controlled substances are regulated by the FDA, and you need to have a DEA number to be able to prescribe um, controlled substances. You need to know the controlled substances schedule for your exam as well. This is very important. Um, Schedule number one, for example, heroin and marijuana, uh, soon no longer will be Schedule 1. It's not accepted for medical use. Nowadays, we know that marijuana is being used as a form of Marinol for wasting syndromes. It is not legally used as permitted, and it's for registered research facilities only. Schedule 2 is no refills are permitted, written prescriptions only, no telephone orders are authorized, for example, or the narcotics and antidepressants or stimulants. Prescription expires in 72 hours if it's not filled. Schedule 3, the prescription must be rewritten after 6 months with up to 5 refills only. Schedule 4 is the same as Schedule 3, but the possession of the drug in big quantities is penalized and is illegal. And Schedule 5 is actually many drugs are over the counter, such as loperamide and many nasal decongestant that have phenylephrine. Um, it's the same as all the prescription drugs, may be dispensed without a prescription. So there's a lot of abuse with this type of medications over the counter. Now, What precautions should you have in mind when you are prescribing controlled substances? Basically, you have to be very careful with the prescription pads to be able to minimize the chances for fraud. These pads should be stored in a locked area, should never be signed in advance or empty. The prescriber's name, NPI number, address, and telephone number should be printed. Unfortunately, you have to know this as it is in your book because, for example, when I prescribe, my NPI number is already printed in the prescription pad as well as my name, but not my address or telephone number. The DEA number or registration number should be designated on all controlled substances prescription if you live in a state that is allowed or you have prescription authority for controlled substances. The prescription always should be dated on the day that it's written. Authorized refills should be spelled out the quantity dispensed. Do not write the number because this number could be changed by the patient. If it's going to be faxed to the pharmacy, with the exception of Schedule 2, try to get the same pharmacy all the time because patients tend to have multiple prescriptions of narcotics be sent to different pharmacies. Try to get a prescription with tamper-proof. Basically, it's actually required since 2009, and this is a good tip for all the prescriptions, not only for controlled substances. So, also precautions and also red flags for patients that are trying to abuse with narcotics. Make sure that the pain is legitimate, is real. I understand that pain is basically subjective, but with rapport and collaboration with the patient, you must, and with a good assessment, you might get an idea if the patient is trying to scam you or not. Dealing with scams consists, for example, in the following steps. Learn to recognize the common cues. Refuse to give the medication to them if you believe that it's not indicated. Try to practice saying no if it's not indicated. Try to develop a paying contract. Be very careful with the prescription altering or forging. Many patients with this type of abuse try to steal prescription. Avoid giving prescriptions in blank or photocopying prescriptions and give them the copy. So, principles for prescribers to avoid this. Again, use chemical dependent screening skills like blood test or urine test. Um, Try to limit the setting regarding controlled substances. Avoid pressure, being pressured to prescribe. Um, Many patients come to the office expecting that they will be leaving with a prescription. If it's not indicated based on your good assessment skills, be firm and say no medication is indicated. Avoid enabling. We try to always prescribe something for any kind of symptom because we believe that we are trying to increase the level of functioning to the patient. And always document. Document a confirmed diagnosis. Is very important to keep a progress note and a good assessment written to support the prescription of a narcotic. So again, try to learn how to recognize the common cues, refuse, say no if it's not indicated, be aware of the forging and altering of prescriptions. So always try to spell out twice a day instead of BID, 5 refills in letters instead of number 5, etc., because that could be changed to a different number. Avoid the pressure to prescribe. Many patients have the expectations that they need a prescription. Um, this would basically contribute to polypharmacy. I already explained the enabling. Basically, that refers to the powerful instinct in practitioners to do anything medically possibly to enable patients with present or potential disability. Basically, we do this to improve their level of functioning. We believe that if the patient has knee pain, they deserve a pain medication to continue walking properly and to work instead of doing a very good assessment and x-ray and try to diagnose the underlying etiology of that knee pain. Communication, uh, try to deal with barriers to communication skills. You have to be able to identify scams. One strategy, again, is to say no. Avoid confrontation. Many times we do prescribe to avoid this type of confrontations with the patient. Um, Carefully chart and document everything you found on the assessment. Physical evaluation of the patient, diagnosis, indications for the treatment, um, expected symptoms outcome, informed consent and agreement of the patient, pain contract could also be included there. Complete history and examination before prescribing is very important. Prescribe limited quantities without refills on the first visit. This allows additional time for assessment and confirm the diagnosis. Educate the patient, educate the staff, and it's important to reinforce the clinical policies of narcotic prescriptions to the staff as well. Obtain, if it's necessary, in the hospital, for example, the collaboration of other practitioners or case managers or social service. Always try to prescribe generic or longer acting formulations. This would avoid side effects and also improves compliance. We discussed this already. Try to develop a pain contract. Use drug screens. So, who decides what a prescription drug is? Federal law basically establishes whether a drug requires a prescription or not. The authority to prescribe or prescription authority is the function of the state, and because of this, it does vary state by state. States have the authority or police power to take regulatory action to protect public health, welfare, and safety, and could include the suspension or revocation of your license. DEA is obtained from the DA department, and that's determines the scope of controlled substances prescribing. We went already through the tips of writing a prescription, so try to use a pre-printed prescription pad. This is important for your exam. That includes your name, address, telephone number. Write a complete drug name, strength, dosage, and form. Write the date of the prescription, current. Use metric units such as milligrams and milliliters, avoid abbreviations, avoid use as directed or as needed, educate the patient on the indications, write dispense as written, write if it's necessary or allow generic substitution, if it's a pediatric population or elderly because of the pharmacodynamics, try to include the weight. Also, in addition, refills, try to spell out the number. Do not write the actual number. Indicate if a safety cap is not required because of children. So, what may be prescribed? Prescriptions are required for all legend and the majority of controlled substances, and this is a question for quizzes and exams. State law may permit the sale of Schedule 5 controlled substances without a prescription in limited quantity. Prescriptions not only are required for legend drugs and controlled substances, but also are required for medical devices, home health, and home testing equipment, needles, syringes, etc. And sometimes it's necessary for some over-the-counter medications through the Medicare and Medicare coverage plan. Electronic medical records now is basically mandated by the Medicare that a certain percentage of prescriptions and progress notes be done via electronic. This basically decreases medications error, and that is the main reason. It's important to know the features and critical factors of informed consent. Remember that a patient must be both legally and clinical competent to give informed consent. And the clinical competency could vary by day or the stage of the individual or course of the individual illness. Because you could be completely normal today and capable of giving informed consent, but if you're under anesthesia or sedation because you need colonoscopy, or because, for example, now you have elevated CO2 and you have CO2 narcosis, you're unable to give informed consent. So basically, it does vary on a particular individual. Now, it's very unethical to prescribe to families or friends. Patient by law is mandated to be assessed and have a medical record in your office or the presence of a clear medical record. So even though I've seen prescriptions being written to families or friends, you and the board could take action against and revoke your license. The sale of pharmaceutical supplements is basically samples. It's illegal to sell pharmaceutical samples and supplements. Now, what are the factors that foster positive outcome? What are the factors that could implicate or go against compliance and adherence? Remember that compliance implies an involuntary act of submission. So basically what is expected is adherence or positive outcomes, which implies a voluntary act of negotiation. Non-adherence to pharmacological regimen can compromise the efficacy of a drug and could lead to failure. So what are the factors that could go against compliance? First and most important, adverse drug reactions. If a patient has an adverse drug reaction, even if it's common, nausea, headache, vomiting, diarrhea, they tend to avoid continuing with the regimen. Cognitive impairment, if patient has Alzheimer's or dementia or because of the course of the disease, you need to be able to educate the proxy or the caregiver? What about asymptomatic diseases? Many, including chronic conditions, in early stages are completely asymptomatic. So it's very, very difficult to convince the patient that they must follow this type of regimen. Sometimes, for example, in hypertension, they tend to do this intermittently. They feel the symptoms of hypertension, they take their blood pressure is high, they take the medication, and then next day is omitted. And that could lead not only to rebound hypertension, but also to ventricular hypertrophy and all the complications of hypertension. Antihypertensive medications, for example, orthostasis, if the patient feels dizzy, they're not going to be taking the medication, erectile dysfunction associated with it, that's another factor for non-compliance. Patients leaving on vacation or visiting a family or having weekend parties, if they know that the actual event is going to interfere with the medication, they will avoid taking the medication. So, if they perceive that there is an out stroke reaction, if there is asymptomatic conditions, including chronic conditions in their early stage, knowledge deficit, just teach the patient about the disease process and the possible side effects. That would improve compliance. Cognitive impairment and psychiatric illness, as I said, try to collaborate with a caregiver or guardian. The complexity of the drug regimen. For example, if this is going to be medrodospac that the patient has to taper it down, explain this to the patient. Don't just give it and write as directed if you haven't directed the patient. The financial impact of the medication, many chronic conditions, the patients are elderly and they don't have a good financial condition to support, for example, um, out of pocket or co-payments, etc. Um, Try to give them the least expensive, generic, uh, and also try to collaborate with social service or case managers or give them samples or pharmaceutical companies. Multiple providers. Always try to obtain a list of medications to avoid polypharmacy. How do you measure adherence? Communicate with the patient. Also, how do you improve adherence? You could basically tell the patient to count the pills, um, make an appointment when the last drug is given. For example, if the regimen is going to be um, for 2 weeks, try to give the next appointment the day after the last drug is given. You could place the medication next to a task that you routinely do every morning or every afternoon. Try to give the patient a written handout at the level of their literacy in their native language. You could incorporate aids such as color bottles or calendars and try to also be aware of their health or cultural belief. Now let's talk a little bit about the cultural and ethical influences. And this is going to be very, very brief, basically to differentiate African Americans, Hispanics, and Asians, and Native Americans. Um, and this is done because many cultural differences or racial differences interfere with pharmacokinetics and pharmacodynamics. You have to be aware not only of the culture but also the economic and educational factors of the patient. And this is because it's very important to educate and train not only the patient but the staff, and that improves the adherence of the medications. It is important for bioavailability of the drug, for first pass metabolism, protein binding, volume of distribution, and excretion. Practitioner may know the guidelines that may sometimes affect specific drug due to racial groups. For example, you would see in hypertension how African Americans respond better to diuretics and not to ACE inhibitors. So, what about African American? Uh, basically, the proportion below poverty line is 24.5, which is high, and their health belief, um, they believe that health is a gift from God, and they have a distrust for the modern healthcare system. So they believe a lot in folk healers and folk medicine. Um, their life expectancy is shorter than the regular population. You need to also be aware not only of this. In addition, they have a high prevalence of coronary artery disease, cancer, and stroke. They have a very low rate of immunizations. Um, for example, I was discussing priorly about an example of hypertension. In ACE inhibitors, African Americans, they have less renin-dependent hypertension. And that's the reason why ACE inhibitors tend not to work very well in this kind of population. But they have a very high affinity for salt, and therefore they tend to accumulate more um, edema. So their salt sensitivity is very high, and this is the reason why, for example, diuretics is the first line of treatment for hypertension in African American. They respond different to alcohol and psychotropic drugs than whites. Um, Indian and Alaskan Native, for example, they have a very short life expectancy, very high incidence for cancer. Health for them is harmony between nature and oneself. Um, the family is very extensive and very close. They have matriarchal and patriarchal leaders um, guiding and directing their health. They believe in the supreme being, and they medicine bags may be worn. Um, Life expectancy is um, around 73 years, and it's actually more for females. Theology and medicine is very strong for them in their belief. They believe in allopathic medicine. They're very well insured, very low degree of unemployment, so they could afford medication better than the rest of the population. They believe that the health is a result of forces that rule the world. They may use acupuncture, acupressure, tai chi, and many herbal medications that could interfere with modern medicine. Islanders, they may require more frequent or higher dosages because they have a high level of cytochrome P450 inducers more than African Americans and Hispanics. They have a slower metabolism for antidepressant. You're not going to be tested in these differential cultures. It's just an awareness. Hispanics, for example, um, very high school education. They have a very strong kinship bond, including with godparents. Um, the family is usually very large, as you could see in hospitals, and very home-centered. Um, they have religious leader that come to the hospital as well, and they participate in the health of the family. Now, they have a very high unemployment level, so they lack access to preventive care and health promotion. They believe in the imbalance of hot, cold, wet, and dry. They believe in traditional healers and allopathic medicine. Most common illnesses are obesity, asthma, diabetes. The non-Hispanic whites, they may hold the belief in the evil eye, so they have healers as well. Um, and they believe also that stress and environmental could change their disease process and health. And this is basically a summary of uh, chapters 4, 6, and 7. Thank you.